So I will speak about 30 years of clinical data, and I will try to present you how was the past, how is the present, and how also you have to consider the future, because science is not static. It's always dynamic. There's always progress, change, and you can predict some of the progress, but of course you cannot predict all the progress. I will take, for example, osteonecrosis first, because I think it's quite simple. After I will speak about non-union, rotator cuff injury. I will speak about a new problem and a new use of stem cells to treat infection. We have data now that have been published and will be published again about the way to use autologous bone marrow to treat infection, because we see that it's a very important problem. And also other techniques of graft improvement, because of course it's a work in progress. Autologous bone marrow concentration for osteonecrosis. I have a large experience. This means that I have some data and some way to improve. I can go quickly for the technique, but we have not only developed the technique of bone marrow concentration, at the same time we have looked how to improve the way to inject the cells. And I have developed a computer-assisted navigation instrumentation for the patients that avoids in the operating room to use fluoroscopy, for example. You can, exactly as we use for knee arthroplasties, computer navigation assisted, we just doing just at the beginning of the surgery 2 X-rays and keeping these X-rays in the system of the computer and using a system of navigation. After, you can go directly from the trochanteric point entry to the osteonecrosis without any X-ray. So there are different ways, not only the stem cells technique, but also you have different ways to improve the technology. So you can, for example, you can improve with ultrasound, but you can also improve with computer navigation assisted for the targeting the site of injection. This is the system. We developed that from the system of knee navigation, and you have some. You put on the trocar a system of diode, and that it's a repair. It's a repair, not repair. It's a look by the system, and you inject directly. You have a line, and you have to follow the line with your trocar to be inside. We look about also, one of the problems, of course, is to know the normality. To say that you are doing something when you treat a pathology, you have to compare to something. But the most difficult is not to know what is the number of cells in the pathology, because you have many patients and you will arrive. The most difficult is to know how many cells you have in a normal patient. It's much more difficult because, of course, you don't do surgery in normal patients. And that is one of the most difficult points in medicine and in surgery. But anyway, we arrive. We arrive to publish that to know how the number of MSC you have in a normal patients with normal bone. And so a normal femoral head, for example, has a number of around 35,000 MSC. This can be considered as a target number of cells in osteonecrosis if you want to have the same number that it was before the disease. But it's not as simple as that, because when you do surgery, you have, of course, a decrease of MSC in the femoral head of patients with necrosis. This has been reported by many papers. And but when you will inject, we will see that, of course, you lost a number of cells. So you have to inject more, a higher number of cells that is normally present in the patients. So another problem is of course, when you inject the cells, what will be the distribution? Because you have, of course, you inject the cells in the femoral head, but you have some venous drainage. And this venous drainage has two inconveniences. The first inconvenience is that you lost cells. But that's not the real problem. You can increase the number of cells. But the most important inconvenience, as regards, at least in France, with the regulatory system, they ask, so you lost cells, but what are going these cells? What do they do? And what these you lost cells, where are they going? Are they going in the liver, in the spleen, in the lungs, and so on? So we have to look about this problem about safety with the regulatory system, and we look not on small animals, of course, because it does not probably have a relationship with humans, but we are able to look that on pigs, on big pigs, and we found that, of course, you lost some cells, but the kinetics is that after 20 hours, you don't find any cells in lungs, liver, spleen, and kidneys. So, even around the joint, you cannot find in the capsule or the ligament or in the muscles. So the cells, most of the cells remain in bone. Some go outside the bone, but after 24 hours, they disappear. They look that probably they mix with the other cells. Another problem is that, of course, you have to resolve is how long time the cells remain at the site to implant. Because MSC, you know, they have cells, they can differentiate, they can do 2 cells, 4 cells, 8 cells, and so on. But have also another way to work. They provide cytokines. And so the question is how long a cells, when you inject in the bone, for example, will remain. And so they remain, of course, not a very long time. They remain. You can find cells during some months, but you can see after two years you have still cells, but after 2 years it decreases very quickly. But you find cells during 2 years at the site of injection. They can repair. We have seen that the cells can repair the bone. They can repair totally, or with a total resolution or a subtotal resolution. And they can provide vascularization. But one of the questions, of course, we had, when you treat a patient, it's not, by definition, he has a disease. So it's not normal. So the question is, when you take MSC from the patient, have this MSC the same function as in a normal patient? So because if you take MSC that have a not normal function, it will not work. So we have to compare, for example, patients with osteonecrosis and normal patients, and look about the functions of these patients, about the number of course, of this colony forming, and also looking about the doubling time of production of these cells. And we found that the patients with osteonecrosis have a decrease of MSC in the femoral head, but the function, some of them have also a decrease in the iliac crest, for example, for patients with corticosteroids. But anyway, the function of MSC in patients with osteonecrosis remains the same as in normal patients. The number decreases, but the function remains sufficient to treat the patient. Another question is one of the most difficult, how many cells are necessary? Because it's, as you know, in pharmacology, you think that there is a dose response, for example, for antibiotics, for drugs, and the dose is maybe quite the same for all the patients. For the cells, the question is more difficult. The answer is much more difficult because how much cells, is it the number of cells the same for all the patients? Is the number of cells the same for all the pathology? So for the first question, I will say that when you look about the literature, you look and you find that there is a large number of variations of cells according to the patient and according to normal patients. It is in the literature, but probably it's not true. For example, for biology, you know that the variation, for example, for each of you is not so large for the number of red cells, for the number of granulocytes in your blood. There is a variation, of course, but this variation is small. For the stem cells, it's probably the same. There is a variation, but in normal patients, the variation is very small. When you do that with the same lab, with the same man that do aspiration, there is no variation. But according to the way the cells are counted in different labs, according to the patients that do bone marrow aspiration, according to the way that they count the cells by colonies, by antibodies reaction, you have different numbers. But from a biologic point of view, we have quite the same number of MSC. There is no large variations of MSC in normal patients. The variation occurs, of course, with age and with pathologies. So how do the cells repair osteonecrosis? It's a good example because you have usually not too much metal, so you can observe with MRI. There are many papers, some of mine, of course, but all those authors that look about the repair and all observe improvement. But you have not only osteonecrosis related to disease, you have trauma disease. This is, for example, a 16 years old patient with trauma, no vascular circumflex vascularization. She had surgery in another hospital. It was not perfect, as you can see, because the reductions and the fractures was not good. So after she had a non-union, I treat the non-union with a valgus osteotomy as was done 50 or 60 years ago. And after, of course, this patient had healing of this fracture. But, of course, she had also osteonecrosis. And so I treated the osteonecrosis by bone marrow injection. And now she has 20 years more, so she's 36 years, and she's perfect. She has just a small irregularity here, but she has no pain, normal activity. She's able to play sport, and she has just a small scar. And this girl was the girl of an orthopedic surgeon, and he was afraid, and he wanted to do an arthroplasty at a girl of 60 years, and it was his girl, so I say, stop, give me your patient, I retreat and avoid the arthroplasty. So you can do also for non-union. It's not only for the iliac crest bone is considered as a gold standard, but it's considered as a gold standard, but it's not so osteogenic. Only 15% of the cells are osteogenic. So you have, of course, a scaffold. And also, when you take a piece of bone graft, a large piece, you have some morbidity in the patient. 30% of the patients at 2 years follow-up have some pain at the site of the bone graft. You can use the way you can use the cells to do the same. This is an example of a non-union was treated with bone marrow injection, and you can see the progression after injection of the callus during the 1 year and a half. This is an example. It was a nurse. She has a non-union, and she had, after 3 months, no callus, and she was proposed to have a plate, screws, nails, but she did not want it in a scar. so she was referred to me, and I just performed a reduction and bone marrow injection, and after 2 months she has callus and she was perfect. This is another example. You can think about also perform several bone marrow injections for the same patients. I have a series of more than, at this moment, more than 50 cases with several injections. This is a severe fractures with blast injury and bullets. And so just performing, and also vascular interruption. So the vascular surgeon could not do anything because it was too distal. So we treat with just cerebral bone marrow injection. At 15 days, we injected bone marrow inside. And after 75 days, we injected also another other cells from the opposite iliac crest. And after 4 months, we injected again to treat the limb lengthening. This is the results. We are just external fixation, injection of bone marrow, and union was obtained, but with some discrepancy. So I performed callus distraction at 4 months and injected in the callus distraction bone marrow cells to get healing. And so the patient at 6 months had perfect healing of the fracture and also healing of the callus distraction for limb lengthening. So you can mix the technologies of cells to the classic way of orthopedic surgery. You can use also with allograft, because it's, for example, for revision of arthroplasty, you need allograft, of course, because you have sometimes severe loss of cells. This is one of the patients that was referred to me. It was, he has 4 or 5 hip surgery, infection, and of course, no proximal femur, no more acetabulum. So I put the patient in traction first to get lengthening of the limb. And after I do the reconstruction with bone allograft on the acetabulum part and a femur allograft for the femoral part, and injected the stem cells everywhere in the allograft on both sides, acetabulum and femur. And so the patients now have 20 years of follow-up. You have indications, of course, for the rotator cuff injury. We have seen that. I can go quickly. We have published two papers, and probably there will be another for 3 years. You can document the way to for soft tissue, because you know that for rotator cuff, it's widely accepted that it's difficult to have healing of the rotator cuff in some patients, and the most difficult part, and we reported that last year, the most difficult part was where we need, how was the number of cells in normal patients without rotator cuff, and where to take the cells. The most difficult is not the pathology. The most difficult when you begin to treat a pathology is to know what is the normality and what you will change with your treatment to arrive to the normality. So we have to perform a service. We look about patients without rotator cuff, and we were able to find that the number of stem cells in the humeral head was around 500 MSc per cubic centimeters. But patients we had tears, of course, a reduction, and also age was a reduction of the number of cells in the femoral head. So we look about control patients, and we remarked that there was a significant reduction of MSc at the tendon bone interface when the patient had rotator cuff injuries. And the reduction of the number of cells was related to the size of the tears, the number of tendons that are tears, the etiology of the tears, and the lag time between the symptoms and the repair. So with this data, of course, you can have an idea of you have to inject cells or not inject cells when you repair a rotator cuff. And we have studies with arthroscopy and a control group. And I will go quickly because it had been described yesterday. And we injected the cells at the site, of course, of the footprint. That means injection of 8 milliliter in the bone, but injection also in the tendon. And I will say that for patients with fat degeneration, that's the more severe cuff tears, I inject also in the muscles to have try to reverse the fat degeneration of the rotator cuff. This is the tear, the repair. And we have the most important point for rotator cuff is during the 6 months. We had no failure in the MSC group and non-healing during the 6 months for some of the patients in the control group. And also, important thing is that when you follow the patient at 10 years, probably when you have injected the MSC, you protect the patients from a re-tear because probably you have increased the thickness of the tendon. You can go on. Also, we find that there was some decrease in the fat degeneration of the muscle when we injected the cells. That's the reasons why in the severe rotator cuff injuries, now I inject also in the muscle for to try to reverse the fat degeneration. So for the question is are mesenchymal stem cells useful to treat degenerative rotator cuff tears? Of course, yes, there is an improvement in healing. From a biologic point of view, the collagen type is increased, but it's not strictly normal. It prevents re-tears, it decreases the evolution of the fat infiltration of the muscle. We are not able at this moment to obtain the specific cytoarchitecture of a normal interface. Probably we will need other solution or improvement, but anyway, it prevents re-tears. It's not so bad as a progress rotator cuff tears. Another problem is infection. Infection is one of the most important problem in the future, in not only in orthopedic surgery, but also outside orthopedic surgery. And we look about, I remarked that I had no infection, and I also treated a lot of septic non-union, and I was surprised during for looking at these patients that usually when they receive for the treatment of their non-union, they have healing, and also we were able to avoid septic complication and to treat some of these patients with septic complications. So we developed another study, and one of the questions was, is it MSC that treats the infection? I know that MSC are able to have some antimicrobial effect, but in my mind, it's probably not that. When you inject bone marrow concentration, it's not, of course, perfect MSC. It's a mixed soup between not only stem cells, but also monocytes and also granulocytes. You cannot, even if you concentrate, you try to remain the granulocytes, but some of the granulocytes remain. So I was thinking that probably we have to look about not only the stem cells, but the hematologic part, and particularly the granulocytes precursors. Because if you think that probably when you treat patients, for example, with when you know that probably perhaps to have a diagnosis of infection, you can mark the granulocytes with radionuclide markers, and when you inject intravenously, the marker go directly at the site of infection because probably there is a chemotaxis for that. So if you look about the treatment of bone infection, in the 30s there was a discovery of antibiotics. During the Second War, the production of penicillin was known. But in 2000, the Nobel Prize, right, the future of humanity and microbes, we evolve as episode of width versus the genes of the microbes. And in 2015, antimicrobial resistance is one of the most important problems of health. The reason is that we have no new antibiotics because the pharmaceutical manufacturers have no new antibiotics in the tube, but we increase the resistance, and you have, we call that the escape. pathogens because they escape to antibiotic treatments in relation with the resistance. And these bacteria are Enterococcus, Staphylococcus, Klebsiella, Acinetobacter, and Enterobacter. And most of these on these bacteria now have a resistance, have a very high problem for most of the countries. So we look about the precursor, granulocyte precursors. But you know that, of course, the white blood cells, polymolecular cells, are the first line of defense. But these cells have a very short time, and these granulocyte precursors are in the bone marrow, and also the granulocyte precursors are in blood. There is a difference between stroma precursors. Stroma precursors are in bone marrow, but you cannot find MSC in blood. Granulocyte precursors are in bone marrow, and you find them in blood because there is a so quick turnover that they are present in the blood. So we do a study to treat patients with infected non-union, and we count the granulocyte precursors as colony, and we look about the treatment and compare 80 patients treated with antibiotics and standard care for a piece of iliac bone graft after debridement. And we compare that with other 80 infected tibial non-unions that receive just percutaneous transplantation of granulocytes precursors. And they were treated between 2000 and 2012. And most of them, of course, had open fractures and the distal part of the tibia. And we look about bone healing with radiograph and also CT scan for evaluation of the callus. So, infected non-union, one arm with percutaneous treatment, another arm with conventional treatment, debridement, and external fixation and piece of bone. These patients, of course, are infected non-unions, so they have some bacteria, but particularly interesting, we have patients, of course, with resistance to antibiotics, 4 patients with Enterococcus, 18 with Staphylococcus with resistance, and so on. But we had the same number of patients with resistance in each group. And for antibiotics, patients with a classical treatment receive intravenous antibiotic therapy, and during 45 days, that's the rule, and after oral antibiotics during 2 months. So it means 15 days of oral antibiotics more. With bone marrow reconstructive treatment, they have just intravenous therapy during 1 week, and no more. And the comparison of two groups, in the standard group, we have 50% of union within 6 months and 87 within 1 year, which is quite correct. With the bone marrow concentrate treatment, we have 57 within 6 months and 90% within 12 months. So the same, there is no significant difference because the numbers are quite the same. And the volus of the callus at the same was similar. So the callus was formed in the patient with bone marrow concentrate, and for the patient who has received the graft, at the beginning, of course, with the graft, they had more bone, but there was some resorption due probably to some subacute infection. But more important, after 8 years of follow-up, with the standard group, 24 patients had recurrent infections despite healing. And most of these patients were with escaped pathogens with resistance. And for the patients who received the granulocyte precursor concentrated, there was only 1 patient with recurrent infection. And the patient with a resistance with escaped pathogen had no recurrence. So now if you look at the reason, when you have in the bone marrow concentration, the number of granulocyte precursors is around 10,000. When you do the concentration for the bone marrow concentrate, you increase the number of granulocytes to 42,000. And of course, with the standard treatment, you don't increase because it's the piece of bone with the granulocytes. So the reason is probably the concentration of the granulocytes. So remember that for patients, for example, with leukemia, when they are neutropenic, they receive injections of granulocyte precursors, and also in bone, in dogs with leukopenia, that had been a way to do the research. We are able to demonstrate that granulocytes are able to migrate to the site of infection. So the patients that have granulocyte precursors at 100-fold higher concentration of granulocyte precursors as compared to the other with the standard treatment. So this may be a way for the future to treat infection, because we think that we think only about antibiotics, but antibiotics were discovered in 1930. But before antibiotics, there was also treatment of infection. And after antibiotics, if you have resistance, there will probably be other way to treat infection. Antibiotics is not the only way to treat infections. So what could be the future for the next years? There are other techniques of graft improvement. The cells production, of course, you can expand the cells by culture. We get the authorization in Europe for some of our patients, not only to concentrate, but to expand the number of cells when the number is too low. You can also expand with or without scaffold, with or without growth factors. We can use also allogenic stem cells. I've used that some years ago. You can think about genetic therapy. At this moment, it's difficult. But you can also think about the way of administration. The way of administration may change in the future. You can inject directly in the bone with or without scaffold. For example, for osteonecrosis, you can think about not to inject in bone, but to inject in the artery circumflex. It's another way to inject the cells. And so for the patients, you can inject intravenously. For the culture, culture is probably also one way of the future for difficult cases. You need 3 weeks of culture, but it's very expensive. We performed at this moment 30 cases, and there are some reports in the literature about expansions of the cells injection after culture. We say that this is for difficult cases because to have an idea, the price of a culture is around $30,000. To give the comparison, in France, the price of the concentration is just $500. So you have the comparison for the same country between the two prices. So it's allowed for patients that have no cells, for example, difficult patients with leukemia, chemotherapy, total body irradiation. Of course, these patients have no cells, so you need to find the cells and after to expand. Allogenic stem cells may be also a way for the progress. Of course, it's not perfect, it's not autologous, but you have patients, for example, we have so many diseases. We have reported in the American Journal of Bone and Joint Surgery one of our cases in 1997. So we are able to treat patients with allogenic stem cells in 1997. It was patients with sickle cell disease, with multifocal osteonecrosis and other pathology as we injected intravenously the cells. The advantage is that you can have a very high number of cells, and the cells go at the site of the pathology. So they go everywhere where there is a pathology. So you can think about that. We inject intravenously for some disease. You can inject also not only in bone, but intra-arterial. This has been done in China by the team of Mao. They go in the artery, in the circumflex artery, and they inject the cells directly, let's see, in the circumflex artery to bring the cells in the bone. So I will say that, in conclusion, the treatment at this moment of autologous concentrate is safe and efficient. We have a large number of patients. We have reported some complications, but about cancer, there is no risk. We have reported in the American Journal of Bone Surgery. The patients with more than 12 years or 15 years follow-up, and there is no risk. The work is still in progress. Probably expansion or allogeneic stem cells could be indicated in some patients. Patients with very severe deficiency of stem cells, patients with multifocal osteonecrosis, probably also for some countries. Keep in mind that, for example, sickle cell disease is a very severe disease, but most of the patients are in Africa and they have no money. So you cannot have production of stem cells in Africa. You cannot think about that. But now, if you think the reverse, you do the production of allogeneic stem cells in Europe or United States, you can send the stem cells in Africa because they have a lot of patients to treat, but they have no money. You have to think about what will be the progress. The progress will be the same as for the automobile car. Before the Second War, you have Rolls-Royce. You have many perfect cars. This car the motor were able to run during 2 million kilometers. But these Rolls-Royce, Bentley, were always for a small number of people. After the Second War, it was quite different. The problem was to provide cars for many people. And when you provide cars for many people, you have to decrease the price. So you provide cars with just a motor that is able to do 100 and 200,000 kilometers. So the progress will be a compromise between the price, the population you treat, and of course, what you are able to do. But anyway, there will be progress and for the next years, and I hope to be able to see that. Thank you for your attention.